Okay, welcome everybody. We've been chatting amongst ourselves and just waiting. We're wanting to just give everybody a few more minutes before we're going to kick off at 6:05. But we just want to really thank you guys for attending. A big shout out to the Australians if you're online, because it's early in the morning here. It looks like we've been up all day, but thank you for the Aussies who are turning up. And also we're in the afternoon for America, so thank you very much for the guys that are making their time. And hopefully you've got a good coffee to take us through our webinar this afternoon. So as you can see here by our presentation, this is the Health Equity and Language Services Practical Steps and Technology Know-How webinar. What I'm going to do now, because we're actually at 6:05, is I'm going to go through and introduce our fabulous, absolutely fabulous speakers. Just another a reminder, we are recording this meeting for those that were not able to actually attend, and we will send this out after the actual webinar. Okay, so I'm going to introduce our amazing panelists. I'm actually going to stop sharing so that we can all see them up close and personal. And what we have here is, first of all, I'm going to ask Debbie if you could introduce yourself.
Hi, yes, thank you. I'm Debbie Lesser. I am a nationally certified sign language interpreter and the Director of Language Access Services for a large healthcare system in Atlanta, Georgia. I'm also Treasurer of NCIHC, the National Council on Interpreting in Healthcare.
Thank you, Debbie. Jessica?
Good morning, good afternoon, happy Wednesday, happy Thursday to those that are in attendance. My name is Jessica Weber. I serve as the Senior Director of Consumer and Patient Experience for Ascension Health. And I previously have worked as a Spanish interpreter and translator, which I think gives me a superpower to understand what it is that it looks like for providers from a user experience perspective when they are engaging with language services. So it's nice to be with you today, and thank you for being in attendance.
Okay. Jackie?
Good morning and good afternoon. My name is Jacqueline Ortiz. I'm the Vice President of Health Equity and Cultural Competence for ChristianaCare, a large healthcare system here in the Mid-Atlantic region located in Wilmington, Delaware.
Thank you. Mila?
My name is Multimila Golovine, and I'm the CEO and President of Masterword Services. We are a language service provider. We work in over 400 languages. And I also worked as an interpreter for many years, both in healthcare settings and child protective settings. So I have an experience of being a language professional as well.
Awesome, thank you. So I'll introduce myself. My name is Karen Hooper from Melbourne, Australia. You might have picked that up from the accent. And I've been in the IT industry for many, many years. I'd like to say I started when I was 12, but that would be a fib. I've been doing things with IBM, HCL, so large companies. But what we've stepped into with IMS, being the CEO of IMS, is we've discovered the language industry and absolutely love it. And we want to serve it as best we can, hence why we're putting on webinars like this. So hopefully you will get a lot out of this. And I, again, am incredibly grateful for the caliber of speakers that we have here and can't wait to hear everybody share. I would also like to introduce Katy Meyers, who is our ASL interpreter, who volunteered at the last minute. Our beautiful Jacqueline Evans wasn't able to make it due to a family situation. So Katy has a cape on, but she's not wearing it today really, but she came in and rescued us at the last minute to provide ASL interpreting. So thank you very much, Katy. Okay, so again, just to let you know, we're recording this. We're going into the Q&A section now, and what we're asking is we'll have a question for each panelist, but we would love each panelist to also contribute to the questions that are being put forward. So we're going to start with Jackie. Jackie. She gave me permission to call her Jackie. So, so in regards to language and health equity, how do you build a language access infrastructure system-wide?
So good morning, good afternoon. I also want to say that I am also a Spanish interpreter, which I did not say in my introduction. And out of all of the things that I've done professionally, and I'm always involved in things that I'm personally passionately involved in, interpreting is probably the most personally fulfilling role. I love interpreters. I love language access. For the potential that interpreters have on increasing the safety and quality of healthcare that our community receives, and also for the potential on the trust that people have in the healthcare they receive and on the emotional impact of the services they receive. So today, instead of me going through the many aspects of how you build an infrastructure, because I would not be able to do that in 10 minutes, what I want to do is share some, what I'm going to call strategic insights on just some ideas that I want to stick with you as I know that there is a lot of interpreter program managers joining us today. So just some food for thought that I'd like you to take away to make your programs more effective in this role that we play. You'll find that in the US at least, and I can't speak for Australia, but in the US we've got a wide spectrum of language access programs that you can kind of put along a continuum. And that continuum goes from on the low end, let's call it, those systems that may have a few phones in a drawer or a closet somewhere. So I'm going to call these check the box programs. In the US, we have a wide variety of language access programs. If you look at throughout the country, you can put them kind of along a continuum of access for language. On the low end, we've got hospital systems that I would characterize as kind of check the box programs. So these are hospital systems in which you may have some phones here and there, maybe in a drawer, where the culture of language access hasn't been fully implemented yet. These situations make me buy antacids in bulk at Costco, because you just know, for those of us who have been in language access, which I have been in language access involved over 20 years, you know that there are patients who are absolutely disproportionately being hurt and not accessing services in a way that's acceptable. And then on the other end of the continuum, which is where I suggest that we all be, is those systems in which health equity is the priority. And what I mean by health equity is when everybody has an equal chance to be healthy and are not kept from being healthy by some social circumstance. So that means that we're as healthy as we can be, regardless of who we are, where we live, or how much money we make. And in order for us to really think about language access in terms of health equity, we have to make sure that we're building language into absolutely every aspect that touches an interaction with a patient or family. And that's a much bigger role. So in thinking about that, you're really fundamentally thinking, how can you build interpreting and access into every absolute interaction with a patient, whether that be a person-to-person interaction, or whether it be a patient-to-system interaction, or a patient-to-document interaction. So I want to share some thoughts about perhaps some things that should be considered in the provision of language services with this health equity consideration. First of all, and these are, I'm only going to offer 3 things because I have a lot of very distinguished fellow panelists that I think we should all hear from. But one thing, the first thing, is that when you're starting to design your system, and particularly that system in which your clinical and your non-clinical staff will be requesting services for patients that are either have limited English proficiency or who are deaf. You've got to start with the perspective of the requester and not the perspective of the language services department. There's so many times when we think about how to set up that system within our health system, but thinking about our convenience and not thinking about what clinicians and staff members need. So you really have to look at the culture of your organization and the workflows. You have to put those request systems in the path of where language service professionals already go to request other systems. And I'm just going to give you an idea around this. There's a contrast between how we do park paving in Argentina and how the Japanese do it. Really different criteria. So in the Argentine case, we have a situation where you have this beautiful design for a park, and you have an architect that sits down and lays down the paths of where they want it to go. And then once they build the park and you have all of it paved in, you find that people are crossing over the paths to the grass, and they're kind of starting to ruin the grass when they're walking through it. So then you put up little chains, and maybe you hire a guard to tell people, no, 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 you can't step on the grass. You've got to walk on these paths that we've constructed for you. Well, the Japanese have another system, and that is before you even design the park, you just raise the parcel of land where you're going to build the park. You let people walk over it for a couple of weeks, and then you look at where you have those ant trails. And then you put the paths over the ant trails, and that naturally makes it so that you're building where people naturally go. So think about it that way. When you're putting out a system like IMS or like any request system, it's got to be placed where it's most convenient for clinical staff to go, not where it seems convenient for us, but really using human factors. Where do you naturally go to request so that it's always point of care accessible? So in terms of where you put the link to those request systems, think there. Where are staff already going to request other systems like transport, pharmacy, environmental services, whatever that is? And that's where you want to make sure that you have accessibility for language access services also. And two, there's a consideration around equipment, and perhaps Mila and Jessica will talk about that too. But really important to think about, again, not in terms of your efficiency as a language services department, but how do staff most immediately access equipment when it's needed? And I'll give you an important image that we have. We have a triage window at Christiana Care that has a nurse sitting on it, and people come in, they sit in a chair behind a bulletproof glass, unfortunately, kind of situation. Now, how do you provide language services at that point if you don't have enough room to wheel in an iPad or the phone out there is just really inconvenient with somebody who comes in emotional and doesn't have the patience to pick up the phone? Well, think about putting an iPad on an arm that's right next to the nurse. So all she has to do when somebody walks up to the window is turn around, turn on the remote services, turn the iPad around to the patient. The interpreter can see the patient can see the interpreter. That's the kind of system that I think is really important for us to think about in terms of language access, is not to build systems that make sense to us as interpreters, but to build systems that make sense to clinical staff and other ancillary staff in hospital systems, so it's easy to use. That's always going to increase the rate at which folks request and use qualified language services instead of other resources. Point number two, again, another strategic insight is remote services don't stand alone. I think one unfortunate trend that we're seeing in the United States right now is that there's a lot of health systems that, to save money, are firing in-person staff. And they're replacing those staff teams. And again, I know of health systems that used to have teams of 30 in-person interpreters in multiple languages that are down to 1 or 2, and that are replacing with video. And that is really now, do I think that remote services are important? They're absolutely critical. We cannot provide in-person interpreters in 200 languages that are requested. So remote services are important. I think they can be high quality. I think they're wonderful components of your language services architecture and infrastructure. That said, it's vital to have a sufficiently large language services in-person operation, because those in-person interpreters fulfill functions that are not restricted only to providing interpreting. And that is critically important. Now, what are those 3 functions? And again, I won't go in depth into these, but that are very important are A, advocacy, B, quality improvement, and C, cultural mediation. And those are three functions that are very, very important. I can tell you a very quick anecdote on how that works and why iPads are not always a substitution for in-person interpreters. We had one interpreter walking through a peri-op area, and I'm going to tell you the very short version of the story, but she heard kind of some commotion around the treatment of a patient. The patient was speaking very loudly in Spanish. She went closer and realized that he was about to go into surgery to have an amputation of his arm above the elbow. But he had only found out about the amputation minutes before he was going into surgery and just all of a sudden refused. Why? Because they had used his wife and his daughter to do that consent process. The wife was also Jehovah's Witness. He was not. She signed a refusal for blood products for him. He was not aware of that. I mean, it was a mess. How did we catch that? It was because the interpreter was walking through that area, and that happens repeatedly. Our manager of operations for language services, Claudia Reyes Hall, is fabulous, and she sets up a system where our interpreters go out and they do rounding constantly on patients that we know to be limited English proficient. And during those roundings, I cannot tell you how many opportunities we find both in cultural mediation, in quality improvement, and in advocacy for patients. That's something that just does not happen when you don't have those teams of in-person interpreters. So building an infrastructure for language access always has to include multiple resources. In-person interpreters plus wonderful remote high-quality services via phone and video are also really critical. And finally, my third and last kind of insight that I'll share with everyone is that it is absolutely a fabulous idea to tap into the linguistic diversity in the employee base of the health system that you're working in, but you have to do that in the right way. There's a lot of programs out there that employ bilingual employees as interpreters without comparable training and preparation of those individuals. We've seen health systems where people have to take like an 8-hour training so that they can interpret, which for those of us who are in the language access industry know is unbelievably risky to the health of the patients that you serve. So do I think that dual role interpreter programs, and this is where you identify, you test, you train, and you employ staff members that work in other roles as also qualified interpreters. Do I think those dual role programs can be absolutely beneficial? 100%, because let me tell you, if you've got bilingual folks working in your health system, they're doing interpreting, whether it's in your policy not to, they're still doing it, because I have yet to see a health system where everybody marches to the tune of the policy 100% of the time. So it's what you plan to do with that interpreting that's going to make a huge difference in how you provide language access to your patients. You have to decide, are you going to train over the skills that are already present in your workforce, or are you going to really enforce the fact that nobody can interpret except for qualified and identified staff? So very important to create a system in which you're mitigating the risk of having folks working in your system that are bilingual with the potential benefit. And we have a dual role interpreter program that has over 100 people in it in 21 different languages. But it's the training and the testing that those interpreters go through is absolutely the same that we require from any other in-person interpreter. It's not less. It's the required number of hours. It's the testing through validated instruments. It's the testing for interpreting skills. So if you have all of those elements plus compensation in place, I think those programs can be very important and very beneficial to expand the amount of access that you provide in terms of language. And I'll stop there and hand it over to my colleagues.
Excellent points. Would anyone like to add to the awesome points that Jacqueline has made? No, I think they're great points. Very, very good. So why don't we move on to the next one, which is Debbie. How do you promote the infrastructure? How do you promote the infrastructure to marginalized communities?
I was thinking about whether or not, I don't know if you saw my mute coming on and off and on and off. I was thinking about, do I respond to Jackie and add to what you said? And actually the question that you're asking me does exactly that. So I'll start where you ended, Jackie. And so I've been on the VRI side of things. I've worked for VRI companies, video remote interpreting companies, and now I'm on the healthcare side of things. So it's interesting to see both sides of the fence. I totally agree with you that that policies, while they are important to have in place, they're not followed. They're not always followed. And I think team members in hospitals, in healthcare systems, are well-meaning. And I can tell you, even though I don't speak, I'm going to use Spanish as an example, even though I'm not a Spanish speaker, if someone came in, I'll tell you, I am a sign language interpreter. So if a deaf person came into the hospital and they're signing and I know sign language, I'm going to sign with them. And it may not be, I may not be interpreting. I may just, welcome to our hospital. Let me take your, your just basic information, just communicating in a basic way. And we know that this happens all the time in healthcare systems. But as far as, and then team members do take it a step further, and those people who are bilingual and untrained will attempt to interpret. So, and that's a big issue for me. So to go back to my question, how do you promote infrastructure to marginalized communities? The first thing is really building trust with your patients. And there's several ways to do that. One is vetting the interpreters in your healthcare system. There needs to be, obviously minimum standards, and we try to hire above, I'm sure all of you try to hire above minimum standards, but there needs to be certain standards for individuals who are going to be interpreting in the healthcare system. They need to be familiar with professional code of ethics, best practices, and of course be able to do cultural mediation, which applies to deaf and hard of hearing patients as well. So there are a few ways to do this. One way is to have a strong partnership with vendor services. Like Jackie said, there's this trend in the States to eliminate in-person interpreting, and from a person who uses a three-dimensional platform as the mode of communication with deaf patients, VRI is not a one-size-fits-all solution, even for spoken language. So I think having a strong partnership with your remote interpreting vendor to make sure that that the values of your healthcare system are being represented by and with your vendor, it makes a big difference and helps to develop that trust. The other way that you develop trust with patients is as they get to know the interpreters in the system, and the interpreters uphold their values. I think that they get to know the interpreters, and that just develops trust. It's like developing trust with your primary care practitioner. So being able to have a team of interpreters that your patients know that they will hopefully run into, even if they don't have the same interpreter at every appointment, that they know there's a pool of people and they're all highly qualified. So how do you determine qualifications? Proficiency assessments are definitely the way to go, in my opinion. There's a wide range of how to determine what qualified means, and those laws change. We know there are some recent changes to the laws that have taken out some of the stipulations that include what qualified is, which I think has kind of moved us backwards a little bit. But so I think it's up to the healthcare system to really put a plan in place to determine what proficiency is and stick to that. Not only for full-time interpreters or those team members that act as interpreters for the system, but also for dual trained clinical staff. So someone who's bilingual, who is acting as an interpreter in their department. In my healthcare system, for example, even if you've taken whatever training you've decided to take, medical interpreter training, whether it's 8 hours, 40 hours, 60 hours, the end result will be that you have to take a proficiency assessment before you can interpret anyway. Because the other thing is, even if let's just use CPR as an example. If I've been trained in CPR, but I use it only every once in a blue moon, I'm going to forget things compared to a nurse in an ED who uses CPR on a very regular basis. And I think it's the same thing with any technical skill. You know, you really need to use it or you'll lose it. And I find that is, we get into a very dangerous area when we use bilingual staff who are who interpret every now and again. So promoting the infrastructure by, I'll just recap, by vetting your interpreters, by establishing a strong rapport and trust with your with vendors, and then ensuring proficiency of the interpreters that you use, I think are 3 really important ways to build that, to promote infrastructure and trust in marginalized communities.
That's awesome. I'll just have to be one of our language directors of language services in an Australian hospital implemented a system over the years of where he had that pool of trusted interpreters that were on site. He sort of moved from outsourcing everything to starting to raise up and train, like Jackie mentioned, having very specific training and assessments and things like that. And he actually was clever enough to do a study of the KPIs of the returning back readmissions and also their length of stay. And it went from something like 6 days in hospital down to 4.5 for their length of stay, and readmissions were drastically dropped as well. So I love that he actually measured from the day that he started it. He measured the whole process, and he could show actual improvements in the service to the patients. Okay, so thank you. Does anyone want to add to what Debbie's added, which were great points? Jessica, sorry.
Jackie, go ahead by all means. Very good. What I wanted to add is also, when things do go awry, whether it's a grievance, a complaint, or a serious safety event, heaven forbid that occurs, I also think that having intentionality and working with risk management, patient experience, and ensuring that we are working with those stakeholders to provide the right interpreting resources so that those that are limited English proficient, deaf, hard of hearing, have those resources, so their complaints, their grievances, and maybe even sometimes compliments are heard by those that are receiving them. So thank you very much, Debbie, for that insightful takeaway from that particular question. But I also think that sometimes when our patients leave our sites is when we find out about what we didn't get right. So that would be my insight for that question.
Jackie, were you going to say something as well? No, okay, cool. Okay, so our next question that we have is for Mila, is to how to create inclusivity for the marginalized communities and those that serve them as well.
Thank you for the question, and it actually allows me to add to what Debbie just said and Jacqueline just said. So we talked about in marginalized communities and language access. One thing I'd like to add is that it's incredibly important for us to continue to build and support interpreters, because professional interpreters are critical in that process. And we often forget when we start looking at cutting costs and we start looking at paying less and less for the interpreters, how that actually affects the overall patient encounter. And we have seen situations where hospital systems have, in their attempt to cut costs, moved to remote interpreting. And then the HCAP scores dropped because the patient satisfaction dropped. And they ended up affecting, actually having a much higher financial impact on the overall bottom line. So, however, all modes of interpreting have their place to exist. When we look at how do we serve marginalized communities, there's so many languages, right? There's 7,000 languages spoken today. Most hospitals have a good plan of supporting maybe Spanish, maybe Vietnamese, maybe Arabic, kind of the top languages. But take a minute to study the demographic of your area and take a minute to look at the refugee communities incoming into your area. Because if you create a welcoming environment for maybe Burmese community, or maybe Vietnamese community, or maybe right now we're going to see an influx of possibly Ukrainian refugees or refugees from Afghanistan coming in, we are suddenly welcoming that whole community to come in. And then you can create signage and maybe those languages that are now have a much higher percentage of limited English proficiency speakers than your normal population. Then also look at, take the time to train the staff in cultural competency. Now, everybody cannot learn every single culture, right? So how do you train the staff in cultural competency all at the same time? Well, the key pointers that I can give, that I can suggest right now, the key giveaways would be that trust is at the basis of trauma-informed care, or at the foundation. Trust is also at the foundation of building relationships with the patients and at patient compliance, right? When somebody trusts you, this patient is much likely to open up and then to be compliant with the treatment plan as well. So how do we build trust, right, when we don't know what the culture is? One of the things to do is be welcoming. Be welcoming. Take the few extra minutes to understand, is the person giving you yes and no answers and they really don't speak English and they really need help? Are they constantly slipping into their native language and they really need an interpreter? Don't assume that they just need that interpreter right away, right? They speak English just because they're giving you yes and no answers. Also, so take a moment of understanding the need for the interpreter. Also take a moment to train the staff in understanding of modes of interpreting. What is a certified deaf interpreter and when do you need one? What is tactile interpreting and when do you need one? When to use in person versus over the phone versus video remote. During COVID, video remote suddenly didn't work because VRI assumed that the patient and the doctor were in the same room. And suddenly they were separated. So a new mode of interpreting came about, was virtual interpreting. What is the limitation to access to technology for marginalized communities? Not everybody has access to technology. So how do you bridge that? And what is the best way to interact? And also, what is the comfort level? So you may assume that, for example, during trauma or rape investigation or working with somebody who's a survivor of trauma, an in-person interpreter may be the best, but actually not always the case. Many times, especially if it's a smaller community, that person would prefer a remote interpreter because that allows them that level of separation from people who know them in their community. And that's especially true for very marginalized languages in very small groups because everybody knows everybody in those communities. So take a moment on how you can build trust with that patient and take extra few seconds to listen to them. Anglo style of communication is called low context also. We come in, we get right to the point and we get, what's wrong with you? Okay, this is what it is. Let me find a solution. Doctors are on a timeline, so many minutes per patient. But many cultures and many people from other countries, they come in and they're from what's called the high context communication, where a person takes the extra few minutes to tell you about their family and their story, and maybe at the level of stress, especially trying to tell you something. And so if you take those few extra minutes to listen, and even if it doesn't make sense to you, it makes sense to that person in building trust. And that brings compliance. Actually, we know that about 40 to 80% of medical information is forgotten immediately, even by speakers of the same language, because the medical setting is a very high stress setting for all of us. Imagine how that is amplified by a person who doesn't speak the language working through then an interpreter. So if you get the patient to be comfortable, then you are going to increase the level of recall, increase the level of satisfaction, which actually will lead to high HCAHPS scores, and a level of adherence, which will reduce those readmissions. So it's a win-win situation for all when you actually take that moment to include all members of the community. Another point to consider is literacy levels. We are encountering some of the speakers, for example, for Mayan languages, where there is no written language to speak of that exists. You have the Mayan language, Mayan hieroglyphics, and many speakers of the Mayan language that we encounter, they actually are functionally illiterate in Spanish and in English. So what we're seeing right now, the written translation, so-called, of discharge documents actually becomes verbal in that place. And so it's a completely different process that is being born out of those interactions. Another point to consider is that people who don't feel that they can be understood by hospital system end up not going to the doctor. What happens is they show up at a hospital at a very acute state. It's now the emergency room visit. The cost of care is a lot higher. And now you're trying to save the patient as opposed to work with preventative care. When the hospitals make members of the non-English speaking communities welcome, people show up at the preventative state, and they end up following the instructions by the doctors, and then the cost of care becomes a lot less, a lot more affordable, and the expense to the hospital system also drops. So it becomes a win-win relationship in that case. In some cases, we also want to consider what are the bridge languages, right? What are the bridge languages to the marginalized communities? So for example, French may be a bridge language to a lot of African languages. Spanish may be a bridge language to a lot of indigenous languages spoken in Latin America, and so forth. And having the signage in multiple languages where a person can identify their language. We now have some tools. For example, we've developed a language identification map where a person can point to their space on the map. And again, that helps to identify what language somebody speaks. All the little things that you can do to make the person welcome into a medical setting. So those would be, I guess, my tips on how to welcome marginalized communities. Another big point is people coming into the country don't really understand the way the medical system works. And it's very, very confusing. And some of the concepts and words don't even exist in that other language because insurance is not a concept that is utilized in every single country. So taking a little bit of extra time to explain how things work that may not be very obvious, so they're not that scary and they're not that overwhelming, is another thing that we can do to help include marginalized communities and to ensure that everybody, like Jacqueline said, has the opportunity to be healthy.
Love that. Really good points, Nella. Any comments? Awesome. I was listening just to normal radio the other day, and they were talking, it's a TV show or where they're talking about life in Australia. And one of the guys said, I didn't know at 14 I was a qualified interpreter for my parents. So you kind of, and that was all I heard, was just that little snippet. And because of, you know, being in the language, being exposed to such amazing people, I went, I bet you what happened. He had to go to the hospital. He became the interpreter, but it was kind of like almost a traumatic experience for him that he is now reliving, which is Jackie, when you mentioned the couple with that now he's getting amputated, that is profound. And I think I love how you're saying, Miller, that we need to be comfortable with, well, we need to understand. And you're right, insurance in Australia, insurance is not a word that we mention in the hospitals. It's just completely different. And I would have to say, even in regards to the captions, not to that, even that is a cultural difference, that when we do webinars, and typically we're obviously Australian, that is not been a necessity we've had to have. So that's a short sight of our exposure and our understanding our audience. So I take that on fully with not having that the technology available. Last but not least is Jessica. And the question we had with Jessica is, what part can technology play in accelerating and building the infrastructure?
And before I start, I wanted to recognize that there is another Ascension associate on the call today, Katy Meyers. She is giving of her time, stepping away from direct patient care in the Ascension, Indiana market. I'm very grateful for her partnership, especially as throughout Ascension, we have embraced IMS. Indiana was the first market to go live, and Katy had an amazing role in that. So Katy, thank you for your fingers, and you are so appreciated. I want to make sure that that is obvious. So as I was posed this question by Karen, I wanted to level set around health equity. And the image that you're looking at that you see is from the CDC. And when you think about tech, it is pervasive. It is part of everything that is language services related. Without it, we cannot provide equity in the services across our health systems, the hospitals, ambulatory care clinics. We have Ascension Living, for example. We have 58 locations wherein there are assisted living, skilled nursing facilities. And so as we look at infrastructure, I wanted to just look at it through this lens, that without a program that is rooted in tech, with tech being leveraged to then identify measurements and best practices around data, really we are not moving toward health equity. So as a level set on the next slide, what I tried to do for the group was across a spectrum of what does tech mean? And we in language services, I think I'm in good company when I say we are word nerds. So I wanted to look through 4 different lenses. The simplest of which are modalities. How is it that we're providing resources, the tools, the devices, the how, the packaging of the modalities that we are. And again, those multimodal approach and that hybrid approach. Language services, apps and plats. The applications and platforms that are developed specifically so that we can operationalize our book of business, our approach to language services, our language access services. And then last and not least, which is my favorite space and how I really feel as a language services leader, we are making the difference and we are broaching the gaps of care. When we are leaving people behind in the healthcare that we're providing, we're overlooking the underserved. And is the interoperability, the integration and synthesis with clinical apps, plats, and then also data sets. So modalities, this is very simple. And for those of you on the call attendees, you're thinking, well, obviously we know this. This is our bread and butter of every day. But for providers that are used to getting an in-person interpreter, oftentimes tech to them is using a phone interpreter, is using a video remote interpreter. And so these are new skill sets that we are beholden to provide education on, best practices on, how it is that these modalities should be used. And I echo the other esteemed panelists at proper times when modality matches acuity, for example, or vice versa, phone interpreting, video remote interpreting. But I also did want to call out the written document translation piece as well as an integral part of the provision of language services. As far as devices are concerned, partnering with Ascension Technologies, for example, IT, telecommunications, how is it that if a provider, a supplier of over-the-phone interpreting or video remote interpreting has an amazing product, an amazing user experience, it is only as successful as the device one is using. So what is the phone that is being utilized? What is the range, for example, of a cordless phone? speaker phones, for example, dual corded phones. Still, they look like they're from the 1980s, but I know that they're salt and peppered throughout your health systems as well. In addition to hospital issued phones, desk phones, ASCOM, Zebra phones, those are two phone suppliers that I know we use across Ascension Health. There may be many others, but how is it that we're using existing resources in the phone space to provide over the phone interpreting, leveraging speed dial, for example, so that it is simply a 3-digit code, no client ID, and we can get that provider to that interpreter as soon as possible. When we look at the VRI space, the devices, the desktop is not leveraged very often, but laptops, tablets, ensuring that the tablets are the largest possible, especially for those that are using American Sign Language so that the interpreter is as visible as possible, hands are as crisp as possible, and then also looking to the future and opportunities where these particular resources aren't fitting the need. And I think a great use case for this is for any therapy services, physical therapy, occupational therapy, when both therapist and patient really need to have that hands-free experience. They don't need to be worrying about that second, let's say, that second handset on that dual corded phone, or is this on speaker, or the volume, or taking, yes, maybe a wonderful tablet on a rolling IV pole, but along with them, when you're worried about your patient ambulating and falling, that is a therapist's main concern, not necessarily an IV pole, but then plus the IV pole in addition to the actual IV pole, that tablet on that pole. So what is it that we're doing to partner with Ascension Technologies? I say that, it comes off the tongue way too easily, but IT, for example, telecommunications, to think outside the box, Bluetooth, for example, devices. How are we using smartphones? And so I think that this is a space where much more discovery and there is opportunity to do better, to be better. As far as apps and plats in the language services space, IMS is a perfect example. And if you wouldn't mind returning, thank you.
Yep, sorry.
How is it that, thank you, yes. And this goes back to what Jacqueline was saying. How is it that we have a systems approach to how it is that interpreters are being requested, and putting those e-request forms in a place that makes sense to the end user? Because at the end of the day, if someone is calling central scheduling to set up their, let's say, their colonoscopy, and an interpreter isn't requested at that time, we're not making it easy for central scheduling to identify the interpreting need and then provide that request per process and protocol in that particular health system, then we are setting that patient up for failure, the staff that is attending to that patient on the day of the colonoscopy for failure. And so the domino effect is something we do need to take into consideration when we're looking at requesting touch points. Likewise, in the written document translation space, how is it that when you have a large health system like Christiana Care, and I'd love to get Jacqueline's take on this as she was speaking, but for Ascension, when we have 14 different markets, ministry markets as we call them, how is it that we are requesting translations, written document translations in the same fashion to avoid duplication, to make sure that we are using quality suppliers, and also understanding what the utilization is and the cost of that niche need in language services. When so many people think of the oral interpretation, I think that written document translation oftentimes gets left out and is equally as important, obviously. And then also translation memory for those health systems that do have on-site written document translators, being able to create that memory, whether it's a Trados, a Deja Vu, those are two products that are used across Ascension. What is it that can help provide to afford efficiencies? You may notice that I left out Google Translate, and that was purposefully because obviously this is not something that is endorsed as a qualified translator, and it's much like a translation memory wherein we do need that in-person translator to be able to proof and provide that best product as ultimately the translation needs to replicate the English original. And it isn't HIPAA compliant anyways. Exactly. Yes. Thank you, Sean. Very true. And thank you for calling that out. Much appreciated. I'm so blessed to be in the presence of so many that are in the know. And when we look at the interoperability, thinking beyond brick and mortar, and Mila mentioned this, virtual care really turned the traditional VRI on its head. And so how is it that we are using our suppliers for video, for phone, audio? Because as we know, video about 50 languages, over the phone interpreting audio about 250-ish. How is it that we're integrating with those platforms that health systems are using for virtual care, whether it be Twilio, Zoom, et cetera? One-stop shopping also, and this is a space in which I don't have a lot of experience, but am very, very intrigued, is the integration of EMR, for example, with the actual provision of language services. And so how is it that that space can be explored for the user experience, that one place for multiple needs, being able to document the patient language, that the fact that an interpreter is in fact being used according to Joint Commission standards, and then also engage with an interpreter. And last and not least, avoiding drip, being data rich, information poor. Historically, language services data can live on an island. How is it that we integrate that data set, synthesize it with the continent of clinical data sets? And so the Ascension Cloud is a Google Cloud. And so how is it that we identify a common denominator in our language services data sets, a patient identifier, so that we're able to look at outcomes, we're able to look at things, as Mila was saying, around geography, around demographics for an area based on comorbidity or predisposition to certain chronic conditions. And in addition to not only our EMRs, but serious safety events, patient surveys, Press Ganey, PRC, for example, and then also CRM platforms. And so really taking the building blocks of the modalities of how we provide the services, but at the other end of the spectrum, really trying to achieve that health equity by gleaning insight, by the data, the documentation, from what sometimes can be an ephemeral encounter if you're just in time using that phone. What does that combination, that aggregate of phone interpreting, of in-person interpreting from FTEs, from agencies, what can that tell us about our communities? And how is it that we can help them live their best health? So, so thank you for that. And I'm not tracking on the chat. I did see Sean's comment, and I appreciate that call out.
Awesome. I'll stop sharing. Excellent. Yes.
I just have one brief comment to add, just in my experience. I think one of the weakest areas is integrating language in the EMR and scheduling, interpreting scheduling. The other part is not just ensuring that interpreters are scheduled for appointments, but when appointments are canceled or change, ensuring that the interpreters are notified of those cancellations and changes, and being able to integrate that into the EMR would just save so much money and so much heartache when a patient shows up and they don't have the access that they need.
Okay. Thank you, Jessica. That was fabulous. We have sort of two kind of questions in regards to, which we're just going to open up to everybody, is just in regards to resources, guides, tools, and alongside of that, what not to do. So I think it's always good to know what not to do. So if anyone would like to add to that, and then what we'll do is we'll open up the Q&A. So while we're answering the next question by the group, if you guys, we have one question. So let's just discuss the resources, guides or tools and what not to do. And hopefully if anyone has any questions, if you could put them in the Q&A section, that'd be fabulous. Go, Mila.
Don't make it too complicated. Because if it is going to be too complicated, it's going to live in isolation from the end user. You want to make it very simple, very easy, like Jacqueline was saying, for the end user to use. So make it very easily accessible and very simple.
That's good.
Agreed with Mila 100%. And I just saw a comment in the chat. It says, do not use bilingual
Yes.
staff. So totally agreed if they are untrained bilingual staff. But I'll say this, you know, we have some really fabulous people at Christiana who are really come from very rich cultural backgrounds, who have really strong language skills, and we've just laid some training for interpreting over those basic skills that they bring to us. Do I think that these programs, again, are both, they're a mixture of risk and benefit? Absolutely. I think that if you can, and we're constantly learning. From the first iteration, we had our first link class, I don't know, 6 years ago. And it's every year, Claudia and I seem to kind of increase the intensity of the program. It's not the easiest thing to get through for staff. But I'll say this, every health equity strategy that you see out there always has an inclusion and diversity component to it. Because I think by definition, it's very difficult to really advance equity if you have a workforce that doesn't mirror the community that it serves. And that includes language. Unless you've lived language barrier either through your own experience or through the experience of your loved ones, it's really hard to catch a lot of those dynamics that we catch. So part of that, you know, you have these gems, because think about it, these bilingual staff members, again, who are trained and monitored, not just, you know, it's not a quick and dirty 8-hour thing. It's full interpreter training, full testing, full verification of skills. If you can have them out there and connected to language services, they are educating their peers. They're especially in Spanish and very frequently encountered languages, they are providing services in those areas where they work. They can be really rich resources. You have to manage the program right, and we're constantly evolving to get that better. But I wouldn't gallop to say absolutely nobody, you know, no bilingual staff, because again, they're out there interpreting. It's happening, whether it's in your policy or not. I would challenge everybody to really, you know, whenever I hear these strong pronouncements of no, our policy says you can't, really, so does ours. But we have a lot of evidence that they're out there interpreting. So how you've got to face that realistically, and not ideally. I think we get to a point where we get very purist in language services. We're like, no, unless you've got, you know, Cervantes out there doing interpreting, they can't do it. Well, let's think about what the risk really is by not addressing the reality that people are out there interpreting, and that you've got to, you know, you've got to have a way to make sure that those people who are not qualified get tested, identified, and eliminated from that function.
Jacqueline, I'd like to comment on that. There's I agree with you about training the bilingual staff. Absolutely. That's because they are indeed possibly being pulled into interpreting. But and having the presence of bilingual staff adds to that welcoming point, where the person will be very welcome, while still the importance of using professional interpreters for the interpreting encounters, so the bilingual staff gets to do their job that they're there to do, and the interpreter gets to do their job that they're there to do. And the interpreters get that extra training and experience as interpreters, because we don't pull interpreters to do nurses' jobs, right, in a way. So everybody stays with it. But I agree with you with the points that you made.
Debbie?
Yeah, thank you. Yeah, I would say the same thing. Again, if you have a staff member who's fluent in Spanish, you're going to build trust with your patient when they speak the same language. So when I first started in my position at my health system, my take was absolutely not. If you're not an interpreter, you can't interpret in the system. And I quickly learned it's happening. Like Jacqueline said, it's happening anyway. So we need to wrap our brains around how to navigate that, since it's happening anyway. So putting some parameters on there that make it very clear who is qualified and who is not, I think is the key to making sure we're doing right by our patients. Jason asked a question that I'd love to address, if that's okay.
Yeah, go for it.
In the chat, he asked, so I partner with a vendor that has helped us set up what we call a direct access line. So, and the interesting thing I'm finding is that my healthcare professionals are very confused about this. I have to explain to them, we have, like Jessica was saying, we have 3 modalities: in-person, video, and telephone. So if I'm a nurse and I would like to call a patient at home, I might use the telephone interpreter as an option. So the number that I provided you is the one you want, because that will connect you with an English speaking interpreter who will then, someone who speaks English first, and then will connect you with the other, whatever the other language is. Whereas on the opposite side, we have a patient at home who needs to follow up with a provider inside our healthcare system. And what traditionally happens is they call the operator is not exactly sure what they want. They try to connect them to the interpreting department. We only have Spanish, they speak Korean. They might get disconnected. We're not exactly sure where they need. It's a mess. So by having a direct access line that the trick is, how do we advertise this? How do we get our providers to let our patients know that we have a direct access number? So that direct access number says, in Spanish, for Spanish, press 1. In Vietnamese, for Vietnamese, press 2. And so it has each language. And then the patient can pick the language they need. They get connected with an interpreter who speaks their language first to them. And then they provide, the patient provides the interpreter with the number within our healthcare system they need to dial. And hopefully it goes smoother from that way. So that's the way we are handling it. But what I'm finding is that it's such a new concept for our healthcare providers that they're confused about how it works. So I'm telling them, call the number and see what you listen to what you hear, test it yourself. And I'm encouraging, I absolutely encourage test calls, whether it be on the telephone or through video. Test it, get yourself experienced firsthand in what it looks like to have an interpreter on the other line. And that way staff can support each other as well.
Awesome. Jessica?
I just wanted to add to what Debbie said, and I think that we can't underestimate a work aid or a QRG or a QR code, for example, that will take our staff to a quick recap of how it is that one can make an outgoing call, for example. And we can socialize it once. And what if that individual is working at a clinic, very few limited English proficient persons? It will be far and few between the instances during which they would need to engage with an interpreter. So I feel that having those resources that have the user in mind and that are housed at an intranet site or somewhere that is accessible to those end users will be extremely helpful as well. And again, we're looking at in-person interpreting, phone interpreting, video remote interpreting, but what if you're receiving that call? That's enough for staff to sometimes be like, oh no, or hang up just out of fear of not communicating. That does occur, unfortunately. So how is it that we provide the tools and the confidence to that frontline staff that are engaging with those patients at the first point of contact many times, which is a phone call?
That's awesome. So we've got some questions here. Let me just read it out. And if anyone would like to type an answer, go for it. But would shifting full-time staff interpreters to the payroll of your LSP be a potential solution to the problem if they were dedicated solely to the system? Patient care would not be impacted and you would gain efficiencies in cost productivity while shifting risk liability to the vendor. Does anyone want to speak to that?
Happy.
Yeah, go Miller. Yeah.
I think it entirely depends on the system. And that is definitely one of the solutions, because you do get efficiencies where you are then not facing the so-called idle time or underutilized time, and that team of professionals becomes a shared resource in a way, right? While still very well knowing your organization. For large hospital system, my personal recommendation may be seemingly counter to a position of an LSP. I would have dedicated full-time staff for certain key languages absolutely present on premises, because then these interpreters really get to know the organization, really get to know the doctors, the system, and then they can be almost subject matter experts to the language providers and to the LSPs out there. So I think it's a combination and a mix of both.
Excellent.
That would be best practices.
Yeah. Now, there's for Jacqueline. Did you want to? I'm sure everybody can read it. I'll just quickly read it. It must be a heartfelt comment about, unless you live a language barrier, it's hard to grasp. Yet most leadership making these decisions about creating systems in support of language access don't have these experience. How do we help open the door to this conversation and avoid the default bilingual staff member can do it?
Oh, yeah. So this is going to be a recommendation for anybody out there who is in any kind of leadership position. You're going to have to develop one very important skill, and that's storytelling. I have a binder full of very impactful stories of things that happen within these walls, not some other organization, but here and documented. So I think that leaders, even though you haven't lived it personally, for the importance of raising awareness to your leadership about the potential pitfalls. And again, unless you have a super robust and completely baked language services program, which few of it, I mean, there's always opportunities for improvement, you're going to find really horrifying stories. That's part of that advocacy role that those in-person interpreters, I mean, I would not even gather even 5% of the stories that we gather if it weren't for a fully operationalized staff going out there, advocating, finding situations with patients. I have an example for every possible argument you can give me to not have interpreters present. So I think storytelling is really key to this, because we can, even though you haven't experienced it, and again, a lot of, especially with senior leaders, by and large, it's folks that travel. At some point, I have found the most ardent supporters in our medical staff to be physicians that at some point in their past got stuck in a foreign country with some kind of health situation with a friend. And they learned actually experientially from that position. So short of shipping somebody off to a foreign country where they don't speak the language and simulating a health emergency, I think that really having patient testimonials and creating educational materials, actually, we did focus groups both with nurses, and we're doing that again now, but both with nurses and with LEP patients who, for example, in a diabetes study that we did, and having that first person storytelling around their experiences, having care at our institution makes you swallow a little bit in the sense of saying, wow, that stuff really happens here. I don't see it. Of course you wouldn't see it, but it happens, and we have testimonials. So storytelling, critical.
Excellent. One of an earlier question by Mark Halal is that about what kinds of training for new staff, graduate nurses, doctors, and that. So I suppose, how do you communicate that throughout for all staff members? And Debbie, I don't know if you wanted to step in as well.
Actually, I was just gonna, I'm not sure, Maria, I'm not sure if I'm pronouncing that right, Perez, your comment in the Q&A about what Jacqueline said. I just wanted to say that that as an ASL interpreter, again, the deaf community, that's a huge, that's a big experience for deaf members of the community. They are very used to hearing society making decisions on their behalf. Hearing members who have no experience with the deaf community or have never met a deaf person before are making decisions on how services should be provided to the deaf community. And luckily, there has been a shift, and there are more deaf individuals that are involved and that are that act as either advocates or advisors. deaf members are being invited to join boards and advisory councils. And that would be my suggestion on addressing on addressing how to make these decisions for spoken language as well. Having someone, both a bilingual staff within your organization who would volunteer to be on advisory council. Most of hospitals now are creating entire departments for DE&I, diversity, equity, and inclusion, that address some of those things. So I think not only having a diverse group of people on an advisory council, but also including your patients, and having patients on that type of a panel is really critical as well.
That's awesome. Cool.
I wanted to address the question about training. I think incorporating training along every part of the journey is very important, because we've seen in engineering companies where safety training is when you enter the building, there's a short safety training video playing where before you get a badge, you have to listen to a 10-minute or 5-minute or 3-minute safety training. So I think the same way as we do safety training, incorporating short training on language access, maybe with a few key points on here's your modes to access an interpreter, including FaceTime sometimes may be the only way based due to technology limitation, when to use a certain mode of interpreting, and having that along pretty much like Jacqueline talked about, again, the Japanese way, right, where the language access happens at different main points where a patient may be interacting with a provider, just like the QR code behind you, Karen. That may be a point of best practices for language access within the organization. But organizations that have implemented that type of training have basically the best results, and then the best patient outcomes, and then the best HCAP scores, and then the best financial results in many different ways.
Good. We've got just a question here, and I think it's a good one. And we're going a little bit over time, but I just want to cover this one. Can you discuss the intricacies related to deafblind patient care? And a shout out that you're all amazing. I think that's fabulous. You are. So who would like to speak to that? Debbie? Yep.
Sure, I'd be happy to start. I would love to hear the other panelists, your experience with this as well. So with deafblind patient care, there's definitely different levels of services to provide. So traditionally, tactile interpreting is what's provided, and most sign language interpreters do tactile interpreting. And that's basically where you're signing in the deaf patient's hand. There is another form of communication called protactile that it's growing. There's a very small group of people that are familiar with protactile, but that's another. I think for sign language interpreters, if you want to improve your skills and grow in a new area, it would be to become educated in protactile interpreting as well. And that's basically where you use different parts of the body to address if really other environmental factors that are going on in around the patient, in addition to the language that's happening. So that's a perfect example of why we can't all go virtual. It's really important to have in-person interpreting. If you can, I recommend, another example, something Mila had said before, this is a little bit off, but another area that you can't do virtually would be group therapy. That really requires an in-person interpreter. There's just too many dynamics going on in the room, and the interpreter on video is only able to see what's happening straight in front of them, and oftentimes can't hear what's happening in the rest of the room. So there's lots of reasons why you would need on-site interpreting. what I have done with deafblind patients before is when there are times where you may not have an interpreter on site, and how do you handle that? I have partnered with a family member to, because they're there with the patient if I'm on video, and I will interpret, but and I'll help navigate the pace with the provider, but have that family member help with that tactile communication. Best practice would be having CDIs available. I have worked with CDIs in both ways, where I have been the interpreter in person and then had a CDI on video, and then the other way around, where we've had a CDI in person and I've been the interpreter on video. So addressing deaf-blind patients' needs can be done in a number of different ways. The other thing that I think a lot of our healthcare systems are lacking is the ability to print in Braille and to provide document translation in Braille. So I'd love to hear if anybody has addressed that. That's something that we're looking into as well.
And when I was speaking about training, the question is actually Jacqueline on qualified bilingual staff. What competencies are recommended to include in the training?
So what I would say is this: it's not just what competencies. You have to go with a fully established program. There are a lot of great programs that you become qualified or licensed to give. We partner with Cross-Cultural Communications out of Columbia, Maryland. So that's Marjorie Bancroft, who I just personally really appreciate in so many ways. She's been a guru for us, but she has a really robust training program. So we go with, established programs that have an identified curriculum. I would really encourage folks not to invent that. So there's a lot of ways of innovating around this, but it's really good to go with proven curricula that have been developed, because that usually comes with a lot of materials that folks have really worked on developing. So I would recommend going with something like that. I wanted to do a quick comment, something that Debbie had talked about before in terms of establishing relationships and trustful, inclusive care environments for marginalized communities. One thing that we've also done at Christiana is create events that are really tailored around communities. So we did have a mammography event, for example, for folks in our deaf community, and it reminded me of that when you were talking about tactile interpreting, because we did have an individual who came who was both blind and deaf. But really important, that gave the community a chance to come in, get some and we worked on that education to really tailor it to the community in terms of health literacy levels, in terms of really thinking about what people were going to see and experience while getting a mammogram. We had tours of the mammography suites to kind of walk them through how to minimize fear around something like a mammogram. And we had the interpreters who usually work with us, plus our in-person ASL interpreters present and interpreting for those encounters. So those are really important events. I remember we got really great feedback. One person who came to that event actually caught a stage 1 breast cancer through the mammogram that they had. So that was that right there was worth the whole event. But really encourage you to think about events in which you create events in which especially in pockets of these marginalized communities, like Mila was talking about mom speaking population. We have in Southern Delaware, we have a growing population of folks from Guatemala and Central America that are mom speaking, and culturally a very distinct group with very particular needs in terms conceptually, just culturally, how to communicate health. So really important to create possible events and encounters where folks can come in on their own terms, ask questions, get familiar, and create relationships are definitely another strategy around that.
Awesome. There's just a comment here. I would like to encourage folks to access people at the end of their program to check interpreting ability. Just because someone has been trained, it doesn't necessarily mean they have developed the skill.
Let me completely agree with Nicole, 150%. If you do not have robust interpreter skills training at the end of the program, don't even do it. Again, the litmus test as to whether you're going to work with bilingual staff as interpreters is if they're going through the same process as you would put your professional interpreters through. So if you're not assessing interpreter skills at the end of training, how do you know if they can interpret it? So they've got to be tested at the end. And again, we've been ratcheting up that. We started with kind of, you know, lesser forms of testing. And every year we seem to get, you know, there's 3 assessments that come at the end. It's written, it's oral, and then there's also an ethics part of it. So more and more using validated tools out there and working with companies to do, you know, vetted interpreter skills assessment. This is, and again, we've evolved over time in this. I still feel, and there's, again, really important to understand there's risks and benefits to those programs, but I think that the benefits outweigh the risks if you do it right, and that's to draw an equivalency between your dual role interpreters and the same process they have to go through as your qualified medical interpreters.
Awesome. Well, we have gone over time, so I hugely apologize. However, I think we could all sit here for hours talking with you guys because you're so amazing. Does anyone have anything they would like to add before we close off?
Offering just contact information for those folks who may want to reach out for additional information or to have somebody just to float ideas past. I know we work with Debbie a lot. We have a roundtable group that meets periodically. It's almost like a support group for language services leaders. So we kind of float ideas past each other, but definitely encourage everybody to create a network of other folks who are in the field, because I can't tell you how much we've learned from Debbie and I'm sure Debbie from us and from everybody else on the roundtable. So join a group and get some support from your fellow language services leaders.
And I cannot be on the program if I don't say this. Make sure that whatever hospital organization you are in, you're aware that interpreters do experience vicarious trauma.
Yes.
And you have support groups that you build for interpreters and support that you build for interpreters to make sure to minimize and mitigate effects of vicarious trauma.
Yeah. And this is a specialty with Miller. And so we really encourage you. What we might do, Miller, is put some information in regards to the trauma that we know you have a lot of tools in that area. So when we do a mail out with the video and transcripts, we will include some points there. Jack and Debbie, I've heard you mention the round table. I'm absolutely fascinated what that is and want to know more. And I think Jessica's going, what is this round table? I need to know. So
it's a secret society with secret signs, but no, just kidding. It's a group of 3 people that found each other. Claudia Reyes-Hull, who's our manager of operations for cultural competence and language services, created just a group of friends to get together, you know, other language services leaders to come together and talk about, you know, best practices and to help each other through sticky, you know, during COVID, through the pandemic to help each other out. So I encourage the formation of those roundtables. I will learn the handshake, I promise.
It actually,
only if
I've
you learn it.
COVID really helped because I think initially the roundtable was within just a certain area of the country, and it just expanded. And so I joined after COVID started. So it's great. It's become a fantastic resource for so many people. So yeah, I think you should definitely join.
And even if, you know, like I love what Jackie said, create your own, you know, raise up, look out to those around you in your community, in your area. The other thing as well, I do want to get out, Jessica, I forgot to say thank you to Katy Meyers, because I know she's an Ascension girl. She's been there over 11 years. She's a qualified ASL interpreter, and I had it written down, but I forgot to say it. So thank you, Katy. You're a legend. And thank you, Jessica, for releasing her to do the interpreting. Again, thank you, guys. You've been absolutely fabulous. I think you've added so much value, and we will try and include as many resources, as many things as, and we'll probably chat with you guys if there's anything you want us to include when we reach out to the attendees. That would be fabulous. So thank you, everyone. I really enjoyed hearing you all, and have an awesome evening and day for those in Australia or in a different time zone. Thank you very much.